Dr. Niteshri, I have initiated the recording. Dr. Teja and Dr. Pradeep, please come online. Start it. Dr. Pradeep lost connection.
Teja, you switch on your video and mic.
Dr. Pradeep exited. We'll wait for him to come back.
Oh, okay, sir.
I request Dr. Pradeep and Dr. Teja to unmute and start.
Yeah, just a minute. I think I had lost the thing. Can I share my screen or?
Wait for them to introduce you once,
Yeah,
and after that you can start sharing. Dr. Niteshri, over to you. You can start the proceedings.
Okay. Dr. Teja? Dr. Teja, can you hear me? Sir, shall I start, sir?
Please go ahead, Dr. Niteshri.
Okay. A very warm welcome to everyone joining us today. I am Dr. Nityashri, head of the Residence Committee, and this gives me immense pleasure to host yet another exciting academic session under the banner of KCIAPM School of Pathology. Today, we have a power packed session lined up for you on leukemias, covering the essentials you simply cannot afford to miss. So, our distinguished speaker, Dr. Pradeep sir, will be sharing his expertise and breaking down acute and chronic leukemias in a very way that is very crisp and clear and resident oriented. And to guide us smoothly through the session, we have our moderator, Dr. Katta Teja. So, dear residents, this one's for you. Sit tight, stay focused, and don't even think of moving away because every single point shared here could be a game changer. So, without any delay, we will be starting our session for today. Teja?
Okay.
I think Teja is having some issues. I think Dr. Niteshri, we can let Dr. Pradeep start his presentation.
Okay, I'll just share the screen. Yeah, it's visible?
Yes, sir.
Yeah. Okay, so it's moving right to the
Yes,
next
sir.
slide.
Yes, sir. Moving.
Yeah.
Yes,
Okay.
sir.
Yeah, thank you. Thank you so much for the opportunity. I'm Dr. Pradeep. I am consultant pathologist here in Neuberg Anand Reference Laboratory. So the talk or the topic which was given today was leukemia lens from blast through breakthrough. Though it seemed a bit vast about how do we cover acute and chronic leukemias together. I've tried to uh, kind of give a outline or a preview basically about how we go by diagnosis and what happens after diagnosis and how the disease gets monitored. So we'll be covering through a few points, but before that, my sincere gratitude to KCIAPM for giving me this opportunity and Dr. A.V. Ram Prasad sir, who's founder here. And then, of course, my teachers back in BMC, the patients whose cases which we will be discussing a lot today, my colleagues here and the technologists, the clinicians who have given us these cases, family, friends, and of course students without whom we would not have learned so much. So when people gave me this talk, when Dr. Nitya called me up and told you have to speak on acute leukemias, I was thinking, was it because of this? Because we did pathogags with Dr. Vijay sir and Dr. Tejasvi sir. But jokes apart, Then when I got this another video which was made, then I thought, okay, they are actually speaking something serious. So here we are, just to start about what leukemia and lymphomas are. Leukemia is derived from uh, the Latin word which means white blood. So when they actually saw these patients with leukemia with a white cell count of being in lakhs together, the blood just seemed so much white, and that's why they called it leukemia. Whereas lymphoma, it's about the lymph, which is the drainage you have for the lymph nodes. There you have a growth or a bulky tumor which is there, and that's why they called it lymphoma. So whenever we do this diagnosis of acute leukemia or a chronic lymphoma, either of it, it's at this point all our focus would be. But then it doesn't stop there. You have to see how these lukes are stratified. Just a minute, I'll okay, not worry. So, how these leukemias are stratified, and whether it's a high risk disease or a low risk disease or any intermediate, based on that, the treatment goes on, and then the disease monitoring. Uh, just give me a second, I'll be back.
Am I audible, ma'am?
Yeah, you're audible now.
Sorry for the interruption. So this where we are. So we diagnose a disease and then we stratify where exactly the disease goes, whether it's leukemia or lymphoma. Based on that, the clinician decides on what treatment has to be given, and then how the disease actually gets monitored. I think this will get more clearer as we move through. So when we speak of diagnosis, what all would we require? Initially, the clinical picture. How suspicious is the clinician on giving it a neoplastic etiology? And then once we look at the morphology, we have to look at the cells which are there on the smear, but also please take help of the cell counter, because the patterns are there in the cell counter to lead you to what, whether there are any abnormal cells or not. But then after that, once we see the cells, we actually type them based on flow cytometry, immunophenotyping. But immunophenotyping can also be done through your immunohistochemistry or even cytochemistry. And then what we actually look in flow cytometry is either there is a deviation from normal maturation pattern or there is an aberrant antigen expression. So, what tests do we actually do to get to a diagnosis in cases of leukemia or lymphoma? First is your morphology, that's your basic. And then, of course, you get through to flow cytometry for immunophenotyping to type which lineage do these blasts or the cells belong to. And then, of course, if at all you have a dry tap and there's only trephine which is there, then you go by immunohistochemistry and there you do the immunophenotyping. Then cytochemistry is also one type where you have MPO available and that can be done. But after that, once your typing is done, then is karyotyping about how your chromosome changes are. And then you also can utilize FISH, which is for your gene fusions mainly, and then NGS to look at gene mutations. So coming to the tests which are only for diagnosis, again, morphology, flow cytometry, IHC, and cytochemistry. But what are we trying to do when we are doing these cells is we are just characterizing what are these cells, whether they are blasts, whether they are abnormal lymphoid cells which are mature, all those things. But basically, when you are looking at acute leukemia, it's more about you are characterizing those blasts. But then when you are doing these tests like karyotyping, FISH, and NGS, you're not actually characterizing it. You're indeed seeing or doing the risk stratification of that particular leukemia. And in simple words, you're trying to say what is the prognosis of that particular disease. So coming to morphology, like what are the things which we can actually look at smear or the data which CBC gives, or basically like the morphological clues which have we have just split it into red cell, white blood cells, and platelets. In red cells, usually leukemias are normocytic normochromic anemias, and they would be a sudden onset, or in a case who have been diagnosed with probably another chronic disorders like MDS or MDS MPN, there is worsening of anemia. So that is a clue for you. Whenever you have anemia, it's either worsening or sudden onset. That has to be a clue for acute leukemia. There may be Role formation, though it is more exclusive for plasma cell neoplasms. It may not be actually so specific. Presence of teardrop cells, because your marrow is getting infiltrated with a lot of these abnormal cells or blasts. So that's one thing which gives a clue. Presence of agglutination. This is more with respect to your CLPDs or mature lymphoid neoplasms, but it can also happen in acute leukemias which are of lymphoblastic origin. Coming to white blood cells, you should know that there should be presence of blast, but is 20% necessary? We'll come back to that. What exactly it means? Like, do we actually have to have 20% of cells every time we have to diagnose leukemia or not? But presence of blast is a must. Do look at edges of smear and the extreme tail, or even at the head part. You will have all this blast sitting there. Look for features of dysbiosis, maybe neutrophils, because those are associated with few disease entities with respect to AML. We'll show that in few cases which are coming, and even abnormal monocytes. Neutrophils, when we say dysbiosis, it can be as simple as abnormal nuclear segmentation. Monocytes, it's just atypical monocytes or even blast equivalents like promonocytes. Coming to platelets, they're usually low, but they can also be normal in many cases. And being a normal platelet count, it does not exclude the diagnosis or a differential of acute leukemia. Recently, we had a case of platelet count of 3 lakh, but it was still acute leukemia. So no matter what the platelet count is, if you have morphological evidence of blasts and other features, do commit it for acute leukemia. And there have been these terminologies like subleukemic leukemia or aleukemic leukemia. These would not make sense to the clinician much, because it doesn't give them a way about what to treat this disease as. So we may actually stop using these terms, because these are not uh, this won't be useful for the clinician as such. All that we have to do is whether there are circulating blasts or not, and what to work up next. So these are the terminologies that are preferred. Either you say there are low blast count, or just say circulating blasts, or even acute leukemic process. And whenever you're reporting a peripheral smear, do avoid the terminologies like atypical cells. If you're telling that, either you commit it as atypical cells, possibly blasts. So either you commit into that, but just the terminology of atypical cells, uh, that terminology should be avoided. And do not commit to any lineage unless there is evidence of differentiation like presence of OR rods. So then you have this like abnormal monocytes which we're speaking, but we had this one abnormal blast which has a OR rod. So just a minute. Sorry for the disturbance again. Uh, so initially you just think there is you have to get this abnormal cell caught or something like that, but to look at WHO coming with so many new entities, it's always so confusing. It's something like this, where you thought it's just one abnormal cell and you have acute leukemia, but it has lot more when you categorize it further. So this from the WHO newest edition, where it speaks about myeloid neoplasms. You have myeloproliferative neoplasms, but you also have MDS, MDS-MPN acute leukemia, and secondary myeloid neoplasm. So when you tell it is more of a chronic myeloid neoplasm, all these things come in, where it is myeloproliferative neoplasm, MDS probably, which are of low blast, you can consider those to be a chronic ones. Even MDS MPN that way are chronic myeloid neoplasms. But acute myeloid leukemia is what our focus should be more in this particular session. This is the uh, article which explains in depth about what how the classification recently is, and you can just put this on Google and you'll get this article, which is a free access. I'll just go through few tables which are confined to this particular article, and this how the myeloid neoplasms are. So you have myeloproliferative neoplasms, and you have these further categories. You should be aware of the first four mainly, and then of course in infancy juvenile monocytic leukemia, because this was previously in the MDS MPN spectrum, and that's the change with the newer edition where they've got it under myeloproliferative neoplasms. This entire thing can be a different completely a separate session, but just be familiar with these entities. And this about MDS, where they have further categorized. Previously, it was just low blast and increased blast, but now they have defining genetic abnormalities as how we speak in acute leukemia. So you have 5q deletion, you have MDS SF3B1, and TP53 inactivation. The reason why they have come up with these is once it's TP53 biallelic, they are more likely that they are a high risk MDS, or almost they behave like how the increased blast 2 or the transformation to acute leukemia is very faster compared to other things. MDS 5q is amongst one of the low risk ones, but once SF3B1 comes, it becomes genetically defined and they have a higher risk of transforming into acute leukemia. And here, this is what is important. Once in a patient, whoever is suspected of MDS or on treatment for MDS and they are following it up, the moment you see a R rod, irrespective of the blast count, it becomes MDS increased blast 2. So no matter you're seeing 5% blast in marrow or 2% blast in peripheral blood, the moment you see R rods, it becomes a higher grade MDS. This is just to show how the MDS MPN spectrum is, which is now has four entities. But in CMML, they have done a few changes where there are two types of uh, CMML. One is myelodysplastic type, and other is myeloproliferative type. And myelodysplastic type is can be as low as that. So even with that cell count, it can be CMML, and that's what we call as myelodysplastic type. And then you have myeloproliferative type, where the WBC count is higher than 13,000. And this is one table where it is uh, where this list has actually increased from the previous edition. But if you look at that, everything has a defined genetic abnormality. We'll try showing you a few cases on how exactly these fusions are and why we have to recognize those. And this is one more category which they have, where you don't have any defined cytogenetic abnormalities or any gene mutation which is there. But in the same article, when you open, they say AML defined by differentiation. Uh, it is anticipated that the number of such cases will diminish as discoveries provide novel genetic context for their classification. So that means they're telling probably this particular entities of differentiation, those will come down because either of these will have something amongst these particular genetic abnormalities which are there. This just about how the ELN criteria is and how exactly the entire horizon of the AML is. So you have the defined cytogenetic abnormalities, but if it is not there, look for TP53. If it is less than 20%, we call it MDS with mutated TP53. If it is more than 20, it is AML with TP53 mutation. If that is not there, look for other genes which become MDS related uh, gene mutations, and then if the blast count is more, it becomes AML. And again, if you don't have any of these gene mutations and you look at the karyotyping, again, if blasts are less than 20%, it is MDS. If it is more, it is AML. If none of this, then it's NOS category. But then you have to know whether it is under any of these, whether it's a therapy related, whether there is a prior disease like MDS or MDS MPN or germline predisposition. And this is a table which is again provided in the same article. I think I missed it, but you can just put ELN 2022 prognosis acute leukemia. You'll get this particular article, and they categorize all the AMLs which are defined as whether it's a favorable abnormality or intermediate or adverse. And this is a very similar article which is for the lymphoid neoplasms, where we initially had for myeloid neoplasm. And the new things which they have come up with is tumor like lesions with B cell predominance. Will not go much into it. And then you have precursor B cell neoplasms, and then you have mature B cell neoplasm. So in lymphoid, unlike how it is in like in myeloid, it's more of chronic, and acute is about all the cells which are there. But here they categorize based on whether it's a mature B cell which is giving a disease, or it's a precursor B cell which is giving the disease. So precursor B cells are the ones which will have all the blasts which are there, but then mature ones are your NHLs, your hairy cell leukemia, splenic marginal zone lymphoma, follicular lymphoma, and many other. But here, the cell of origin is your mature lymphocytes, and from there, all this neoplastic process starts. Whereas here, it starts from a very immature precursors or the lymphoblasts, basically. So that is one thing which you have to know when you're trying to see what exactly it is in a lymphoid neoplasm. Are we looking at blasts and then your immunophenotype proves that these are immature cells? Then it is acute lymphoblastic leukemia. But then, if at all it's all the mature cells which are there, it becomes a chronic lymphoproliferative disorders or NHL. And once NHL, so there are two different things now when we know about the chronic neoplasms in myeloid lineage and chronic neoplasms in lymphoid lineage. Chronic neoplasms in myeloid lineage, they always get into a acute leukemic transformation. You eventually get all the myeloid blasts and they transform into acute leukemia. Whereas in CLPDs, they just get into a larger cell transformation. They would not become a ALL. From CLPD, they never become acute leuk, as in like how it is in myeloid. They always, it's just about let's say it's a case of CLL. It's always about they transforming into a DLBCL, and you just say it is a large cell transformation, because when you do the immunophenotype, the cells are still mature B lymphocytes, and the immunophenotype is as same as a mature B cell B lymphocyte. So that's one thing which we wanted to convey about a CLPD. It's always about a large cell transformation because the mature kind of character is still there with the cell. This is just the same with T cells. So again, you have tumor-like, precursor, and mature T cells. So always there has been a question about that: is the uh, cell count always necessary? Do they always present with leukocytosis and stuff? And this is just a recent study which we did, and these were the cases where little there was no suspicion of leukemia in most of these cases. And out of 190 cases which we just analyzed, 93 of them had a total count less than the normal for that particular age. And out of 20 cases of acute promyelocytic leukemia, almost 50% of them either present with a normal WBC count or a very low WBC count. And it can be as low as 515, as in one of our cases. So coming back to what we are looking at, so diagnosis we spoke on, and about we have to do the risk stratification and speak on prognosis. So these are the tests which we spoke on. It's just for you to revise again about what exactly each test role is when you come to diagnosis. I'll just these are the repetitive slides. But then, when if you're doing a marrow for a case of acute leukemia, or if you want to send a test basically for a case of acute leukemia, what test requires what exact vacutainer? I think that knowledge has to be there. So, just thought I would keep this. So, for morphology, it can be just a direct smears. If you're doing marrow, it can be imprint. You can even get the morphology if the aspirate is in a EDTA vacutainer or even in a sodium heparin vacutainer, but EDTA would have less amount of artifacts. So that's the thing. So viability and cell preservation is better in EDTA. If it's immunophenotyping, it can EDTA is the preferred vacutainer, but if you don't have, sodium heparin can also be used. But again, coming to the cell preservation and viability, EDTA is much better than sodium heparin. Coming to karyotyping, it has to be only in sodium heparin, and viability is preserved up to 72 hours, even if it's room temperature. So you need not actually, if the lab is somewhere far and you have to ship it, make sure it's at an ambient temperature. It's refrigeration may not be even necessary, but just make sure it's there. But for karyotyping, if you have to do about the chromosomal abnormalities, sodium heparin is the vacutainer. So refrigeration is optional basically. And then fish, it can again be a sodium heparin vacutainer. The same sample can be used for karyotyping both. So fish and karyotyping, sodium heparin. But EDTA can also be used if you have got sample only for, let's say, flow, and you think it is uh, acute promyelocytic leukemia. The same EDTA can be utilized for fish PML. So same with this, the viability is preserved up to 72 hours of room temperature. Refrigeration can be optional if when we are speaking about fish. And again, sodium heparin is better than EDTA. Coming to NGS, EDTA is the only preferred vacutainer. So for karyotyping and fish, it's sodium heparin. For flow and NGS, it is EDTA. But in this, viability is preserved even up to 14 days at room temperature if you are doing any DNA assays, if you want to look for NPM1, SEPA, or any of those gene mutations. And if it's a DNA assay, it's viable even up to 14 days, that's 2 weeks. And again, refrigeration is optional. But if it's a RNA assay, it has to be refrigerated and it has to reach the processing center within 48 hours. So these are the few things. So if you're doing marrow, it doesn't stop at morphology. You have to know that we have to collect samples for flow, karyotyping, fish and NGS because we have to stratify them. So we'll have a few scenarios about these are kind of FAQs which I receive a lot and thought I would just make it to a scenarios based. So middle-aged male presenting with leukocytosis which is 90% blast. So morphology is acute leukemia. Is marrow necessary? Definitely not. So, what test can be done in peripheral blood is the question which we get often. So, flow cytometry can be done, fish and cytogenetics can be done because it is leukocytosis and the blast proportion is 90%. And even NGS can be done in the same sample. So, three things. Coming to scenario two, we have a 5-year-old boy, a total count of 4,000, and 80% are abnormal promyelocytes. So, morphologically, he is acute promyelocytic leukemia. The question is, what test can be done in peripheral blood sample again? So, you can do flow cytometry again because your blast proportion is more. You can do fish PML rara again because the promyelocytes are so much, and of course, like PCR for PML rara. This test would be more preferable rather than fish because there are three different transcripts of PML rara. If we know that in the baseline, the disease monitoring further will become easier. So peripheral blood sample can be used for all this when you have higher proportion of cells, no matter how less the total count is. Now we have a 26-year-old female, peripheral blood is 1000 count and blast is 2%. Now we say possibly there is acute leukemic process. Now what is to be done next? We say bone marrow examination as these can be packed marrow, so for which trephine would be necessary. Flow cytometry with whatever material you can get from the aspirate, and fission cytogenetics for the associated abnormalities because we have to stratify them. Just that thing. So because the blast percentage is low on peripheral blood, your marrow would be the go-to choice. Coming to the next scenario, 32-year male and fever and has thrombocytopenia. Blasts are 10% and we are seeing dysbiotic neutrophils. What may be the impression now? You can just say blast with dysbiotic neutrophils, but should we categorize them as now let's say we do marrow for this and we have very similar proportion of blast and there's dysbiosis. Now the question is it MDS with increased blast or acute leukemia? Now since we are speaking about a young adult, it's always likely that this is not MDS and rather we are speaking of acute leukemia with some defining cytogenetic abnormalities. So if you do this test again, so immunophenotyping, you have myeloid blast of 12% and there is aberrant expression of 19 and 56. So that means we are looking at an abnormal myeloid blast. So once this is there, your question may be that is it MPAL because we have a B lineage defining antigen here. But for that, I think I forgot to put that picture of what exactly the criteria mentions on MPAL. But even if you open literature, they just say if there is a AML with aberrant CD19, you have to rule out a 821 before considering MPAL. So FISH was done and RunX1, RunXT1, which is your 821. So 56 is more associated with KIT mutation positive. So what initially was just dysbiotic neutrophils with blast and with a blast less than 20%, your defining abnormalities actually get them stratified. And once KIT mutation comes positive, the 821, though we saw in the table that it's a favorable prognosis, it almost gets into a high risk AML. I'll show you some cases regarding that. And this is one thing which 2016 and 2022 differs from. Initially in 2016, there were only 3 entities A21 in version 16 and PML RARA, where they said irrespective of the blast count less than 20%, you call this AML, but it was controversial to call other ones. But in the new 2023, it just says if there is KMT2A, MECOM, Nuke 98, a blast under 20% is still acceptable because it's a defining abnormality. So I'll show you a few cases about uh, the thing which is there. So this is the thing. So if at all, if it's only abnormality is T821, it's a low risk AML, but with KIT it becomes a high risk AML. Coming to another scenario, there is leukocytosis. There are 3 lakh counts. Morphologically, myeloid shift, basophilia, eosinophilia, and blast of 4%. So we are looking at CML's chronic phase. And what next test in the same peripheral blood? Just go for karyotyping, FISH, or RT-PCR. Again, RT-PCR here is much better test investigation because again you will know what the transcript is at the baseline, and that will help in disease monitoring. So scenario 6, you have a 2-year-old boy, peripheral pleural effusion, which is there, and the cell count is 20,000 in the fluid. Morphology, you have large lymphoid cells, which are 90%, and possibly Burkitt lymphoma. Now, what tests can be done in the same fluid? You can do flow cytometry to characterize those abnormal lymphoid cells and see whether it's Burkitt. And then FISH for CMYC on the same. You can do a cell block out of it and do it, or even culture the fluid and can get it done. So either ways. So no matter which sample type is, you just have to know like what is your proportion of cells and what next test can be done with the same sample which is there. You can just answer this like you can, since there's no interaction I feel with this, so you can just choose one of the choices for now and keep it with you. We're just asking what is it doing, so just choose any of the options and keep that with you. We'll come back to that. And this is one of my favorite movies where he keeps about like there was that concept of drone which came up. So why are we putting this here is it's all about what initially we thought, that morphology is probably so different from what the patient might go through and all that. Like we are just so focused on morphology, but then I think integrating everything is what can give you the entire picture of what is happening. If at all we just probably look at the pitch, we may not even know whether the match is happening, but maybe with this particular thing we know that it's happening in a night time, and probably with white jersey it is a test match with their which they are playing. So integrating every aspect after what you see the cell under microscope and getting to the molecular level, that defines, and that also helps about you will have the complete picture on how that patient behaves once the diagnosis is done. So I have a few cases which are there, and I think we'll just probably wind up. Probably there are some about 6 cases. So this 32-year male, and there is persistent thrombocytopenia. And if you see, WBC count is 12,000, and hemoglobin is 11, which is just mild anemia, but 47,000 platelet, that is quite low. So this is where we want to tell that there should be emphasis on how the cell counter data can be utilized, because there is so much in it. It need not, like, if we are looking at 100 smears every day, we need not look for everything in every single case. We need not look at malaria in every case. We need not look for blasts in every case. But looking at the cell counter data before putting the slide onto the microscope, it may give clues on what all you have to look on. Now, this is from Sysmex and this is from Horiba. I've just put the manufacturer just to, uh, because if you have that, you have to know what axis these are. So in Sysmex, it is fluorescence and side scatter, whereas in Horiba, it is the side scatter is on the y axis and forward scatter is on the x axis. So based on that, the side scatter higher one is your neutrophil. So here also it's there. So but then uh, we'll just uh, probably I should have put a normal one beside, because the normal ones would come here and we are almost seeing the hypogranular neutrophil, which is a dysbiotic neutrophil. And then whenever you have the merge between these cells, you think of blasts, very similar with what happens in the Horibo also. It's more about the cell counter gets kind of confused and it won't be able to place exactly what kind of cell it is. And that's where it may say there are monocytes in some, and it may say it's just neutrophil in some. But you would know that this is not normal if, like, get familiar with your normal and you know that these are abnormal. So with that, we know that we have to look for two things. One is a dysbiotic neutrophil, and one more is blast. The same thing happens with cell counter. If it's a three-part, you have blast predominant in that. So yeah, so this is the normal of that. So once if you see the neutrophil, it's almost shifted to the left side. That means the side scatter is low. That means you have to look at a hypogranular neutrophil, which is dysbiotic, and then the merge which says that blasts are there. So with the same thing with Horiba, so there is a merge between these two here. So this was the morphology. So you have hypogranular neutrophils which are dysbiotic, and you have blasts which are there. And one particular blast has a single slender or rod. So now the question is it again blast with dysbiosis which is there? Do you call it MDS with increased blast? Because the blast percentage was somewhere around 15 in this case. But then karyotyping was done and this was 821 AML. So whenever you have a young individual, probably between 18 to 45, and you have these dysbiotic neutrophils along with blasts, always look for these hints on how the or rod looks, and that might be a clue for what diagnosis it is. But then we can't stop here at what exactly like T821 is, and here it is. If you open the classification, run X1, run X1 T1, and if you see again, this is what we are speaking. So it comes under favorable prognosis if it is this alone. But then if this is our statistics, where if there is soft tissue mass or even a lymph node, which are all myeloid sarcoma components in this particular patients, they always do bad, because 5 cases with what we have followed up, the ones who presented with soft tissue mass, either it was in retroperitoneum, one kid had a cervical lymphadenopathy, one person had just a cellulitis. So those, the mortality was very very higher, and it was just 2 months from the time of diagnosis. But 14 cases where we had only leukemic presentation only, and without a C kit or a aberrant CD56 or anything in flow, they went into remission with high dose. And one of this particular patient which I showed, he was diagnosed way back in 2017 October, and he's been in remission with just the chemo. And that's how good they can behave if it's only leukemic presentation. But coming to disease monitoring, again, it can be MRD by flow cytometry, or just take this gene fusion copies of the next one T1. So that can be part of disease monitoring. Or we have a next case where it's a combination of 4 cases which we had seen who are spanning between 17 to 35, and this was a typical history: fever of 2 weeks. Initially, there was thrombocytopenia, but end of 2 weeks, there are associated cytopenias like anemia and there is leukopenia. So these were the cases which are there. So we have 1,000 count, 7 hemoglobin, 13,000 platelet count. Again, total count of 1,000, hemoglobin of 9, platelet of 5,000, and then WBC again in another case 1,000, again 1,000. But everyone has severe thrombocytopenia and severe leukopenia. So whenever you have such thing where the cytopenias are worsening, that means your normal marrow component is getting reduced. That's only because there is something infiltrating the marrow. There may be some abnormal cells which are coming into marrow. And when we look at the scatter patterns of these, you always have the cells which are almost having a high side scatter as with the neutrophils. So a large cell, so again we'll just go to other cell counters. So this is the forward scatter and this is the side scatter. So they are granular and they are large. So there can be only one diagnosis with that. This is from Beckman, where all the cells which are there are sitting in the blast region. The WDF plot I don't think I put, but that was in neutrophil region. So the cells which were sitting in neutrophil regions in the scatter plot, but they were in the blast region on the histogram. So everywhere you're looking at a large cell which are granular, and those should be promyelocytes. So, but once you know it is promyelocytes, you have made the diagnosis of APML, always communicate to the clinician because the mortality is very high. And why we have to do that is because they are extremely well treatable. And this was one of those cases of amongst four, and the boy is still doing good. And we often, so again, it's the same thing when you look at PML RARA, it comes under one of these categories. Now, how do we monitor disease in these patients? Again, you can just do a PML RARA gene fusion copies quantitative whenever the treatment is done or through the maintenance. But then there has been this question always about, do these patients present in a very critical state? Definitely not, because we've had these two cases last year where it was just a case of pilonidal sinus, and this girl had just a pain in her calf region, and she was just sitting in the office when she just gave this thing about one of the physicians told we'll just do a CBC still. And here also this was just a routine thing, pre-op workup for a pilonidal sinus, and they told okay we'll just see what it is. But they were concerned about why platelets are low, and these two are APML again. So they may be not sick while you are diagnosing almost, but probably if they hadn't come, at least like if they had come 2 days later, the story probably would have been very different. And these two are doing really good right now. And this is just one of those slides I think I had put in KCIAPM also. It's about how the OR rod can define the genetic abnormality. If it's single slender, you often see that it's in A21. And if it is very needle-like, that's more in APM. So this is another case where you have this person presented to orthopedician because it was a bone pain, and all that was there was abnormal blasts. So when we look at blasts, you have these cells. So you have this cup-shaped nucleus which are there. So cup-shaped invagination, and you have these particular cells, and that is there across again. I think recently in the slide seminar of Kidbai, there was very particular thing, and this always almost points to NPM1 mutation. And why you have to know it? Because NPM1 alone is again a favorable acute leukemia which is there. But once there is FLT3, they often go into a adverse or a high risk AML. So the same thing. So mutated NPM1 without FLT3, that is favorable, but mutated NPM1 with FLT3, the disease kind of advances. So with if it's just mutated NPM1 without FLT3, as in this particular case, he was just given high dose chemo and then through the maintenance, and he's been in remission. So, but if at all FLT3 ITD comes, the kind of treatment is kind of aggressive. So again, here disease monitoring again can be just a MRD inflow, or it can be NPM1 mutation copies assessment. That can be your disease monitoring. Coming to the next case, so this was the scatter. I don't think I will go much in detail to this. Just to uh, tell, he had just a persistent anemia that was going on for like 4 months now, and every time he just checks, the hemoglobin is going even further. It was 10 a couple of months back, and it came to 8.5 now. But other cell lineages, total count is normal, platelet is normal. With this, we could just think that there is some hypogranularity, if at all. So we just went through the smear. You have hypogranular neutrophils, which are there, some toxic changes because he had fever at that time. And then there were these blasts, which were there about 4% in circulation. And then this abnormal monocytes. So we didn't know what exactly we were thinking, but we are speaking of a patient with persistent anemia and who has dyspoetic neutrophils and blasts which are in circulation. Marrow was done for this patient, and there was a dysplastic megakaryocyte. Further on, we had done iron stain, which is part of your marrow, and he had ring sideroblasts. With that, we thought persistent anemia, probably some circulating blasts, and then ring sideroblasts. We thought this can be just a MDS with these dyspoetic megakaryocytes and some scatterblasts. So the clinician told, okay, we'll get a fish for this particular patient because it is MDS. But then fish panel came no definitive abnormality related to MDS. But then they had also asked for karyotyping, and karyotyping revealed inversion 3. So where does this inversion 3 comes when we speak of in the acute leukemia classification? So this is the same slide which we had put earlier. They had told inversion 3, it's controversial if to call it leukemia if it is less than 20% blast in 2016, and 2023 they say this is your inversion 16, sorry, inversion 3 MECOM. So the blast for under 20%, so this becomes a direct acute leukemia inversion 3 because your blast percent does not matter and there is a defining cytogenetic abnormality. And this is where your inversion 3 is, which is amongst adverse prognosis. That means it's more of a high risk AML, and the treatment is more often towards transplantation once they go into remission. So for all the high risk acute leukemias, basically once they get into remission, that's when they get for transplant. This is just another case about how to word it when you have low cells. So you have persistent leukopenia in this particular uh, kid, and like 9.5 hemoglobin. So the anemia is there and total count is on the lower side, but there is fever which is there since 2 weeks. Again, we just looked at the scatter and there were few elements here. Just looking at the RBCs, nothing much. Again, you look at all the other cells, seems normal. But then there were these, again, about 3% or 2% circulating blasts which were there. And this is how I think, okay, 6% is what we put it as. So if you have such cases, you can just say there are cytopenias with 6% circulating blasts, and possibility of acute leukemic process has to be considered. And we did marrow for this particular patient. It was a packed marrow, and this was a BALL and with hyperploidy, and that's a favorable prognosis. I think we have about another few cases. I'll just wind it up. So we have another case which is more of elderly female anemia in since 2 months, and she has massive splenomegaly, and if you can see, it's isolated anemia. Platelet count is normal and WBC count is normal, and you have macrocytic anemia. So looking at that, we just looked at the morphology, and there were few of these small agglutinates. Always in an elderly, if you're looking at that, get a DCT done, and once it's DCT positive, always look for abnormal lymphoid cells which were there in this particular case. Marrow was done for this particular person, and because there was splenomegaly and anemia, this was the pattern of infiltration in the marrow, and it was in nodules basically, and this was splenic marginal zone lymphoma. So whenever you have anemia in an elderly and you have autoagglutination kind of thing, persistent anemia, always with DCT positive, always look for lymphoma which is there. This is just another article on how exactly the NHLs are, and this is probably 2008, but it still is very reliable. And they classify BCLPDs based on the expression of 5 and 10, and you can just go through that. And same with the T and NK cells. So you can just put as Craig and Foon and CLPD, you will get this article, and this is the in blood. Just go through that, and this one of the cases which is there now, like he had effusions in pleural and peritoneal, and again there was leukocytosis, and they did a PET and it lit up everywhere possible. But what cells we had to look for are some large but probably abnormal, and this was how the morphology is. We thought initially it's a degenerated sample, but it was just drawn probably 4 hours before we did this smear. And whenever you have such morphology in case who is intact, like a sample which is intact, always think of bucket. And this was semic positive, did flow on this, and it was classical bucket lymphoma, but in a leukemic phase. So this is what we wanted to emphasize. So if it's a mediastinal mass and there is a T cell precursor lymphoid neoplasm, you call it T lymphoblasts which are there. If it's only mediastinal mass, you call it T lymphoblastic lymphoma, or if it is a B, you call it B lymphoblastic lymphoma. Whether if it is uh, confined to, let's say, pleura or mediastinum or a lymph node, you just call it that. If there are no circulating blasts, you have to call it lymphoblastic lymphoma. But once it gets into circulation, like how it is in this case, you call it a leukemic phase, or that's how your T lymphoblastic leukemia or B lymphoblastic leukemia is, because they are in circulation. So that's one thing. So just to cover it up with MDS MPN, it's just that this is how your myelodysplastic type of CMML would look, because there is dyspoetic neutrophils and increased monocytes. So this is the MDS component, and this is almost the MPN component. And this is how a myeloproliferative CMML would be. So you have dyspoisis, but you have a lot of cells. You have left shift and everything along with monocytes. So this is how. So this was count of 4,000, and this is a count of 18,000. So this is MPN type of CMML because the total count is more, and here it is MD or a dyspoetic type of CMML because the count is less. So this was the morphology. You have dysplastic neutrophils, and then you have abnormal monocytes, but this is probably which has transformed because blasts were more in the other one which we showed this case particularly. And then just to cover on what exactly MDS can be. So you have refractory anemia in 48-year-old. You know that there are dysplastic neutrophils. And then bone marrow was done for this particular case, and megakaryocytes are monolobated, hypolobated, and which is classical of a 5q deletion. Now, why 5q deletion? Now, there's the same case where from this, where there is literally no merge between these, and there is merge, which means The patient is on treatment, and probably we are looking at circulating blasts and despotic neutrophils. There were circulating blasts, and this person was already SF3B1 positive. So, though it was 5Q, once it is SF3B1, they have a higher chances that they can go into acute leukemic transformation faster. So, that's a disease progression in MDS. So, just to conclude, acute leukemia is not so uncommon. And coming to the age distribution, uh, like it's so much common in any age group now. Particularly, there has been a rise in incidence between the age group of 18 to 45. And whenever those have dyspotic features, make sure you're counting on a genetic abnormality rather than calling it MDS. And always follow up and make sure you have, if you're doing a marrow, make sure you have enough samples, because the complete workup is necessary. And we probably have to reduce usage of FAB terminology unless it's promyelocytic leukemia. There is nothing else which would help the clinician to take a call on what exact treatment it is. Even if we call it monocytic or with maturation or without maturation, all those things would not matter. Once you say it is promyelocyte, only M3 that has got weightage. Otherwise, rest of it is probably more. You have to get into that genetic terminologies, and always think of acute leukemia when it is anemia and there is no definitive cause. When there is the nutritional workup has been done and it is normal and everything, always think of acute leukemia, or even thrombocytopenia for that matter. And all, it would be better if you can integrate your morphology with cell counter, because it can tell whether this patient can suspect it or not. So this is one of the cases of MPN who was primary myelofibrosis initially, and who went on to a leukemic transformation in no time. Literally, it was a gap of probably 18 months. And initially, when we had done marrow and got every workup done, it was just JAK2 and nothing else. But I think on further, there were gain of a lot of mutations, and it transformed into acute leukemia. So this was the thing which I had asked about, what exactly. So just look at what all options you have, choose one, and that was the thing. So three would have been the ideal answer. So, and this is one thing from Mankuti Manakaga. I keep quoting this every time, which says Gupta Gamni Runa, which means you don't know, like even a smallest thing which you're doing and recognizing that acute leukemia, it can be a world to that patient. So thanks to everyone and this our team. Yeah.
Thank you so much, sir. As a passionate teacher, we already had a privilege to listen in this class like before in CMAs, and we are extremely honored to have you with us today. And sorry for the minute inconvenience in the beginning. So thank you so much.
Thank you. So there's no Q&A, nothing. Okay. Yeah.
Sir, as of now, we have not received any questions till now.
Okay.
That was a very great talk, sir. On behalf of the KCIAPM Residents Committee, I take the great pleasure in thanking our esteemed speaker, Dr. Pradeep Kumar, sir, consultant pathologist and head of hematopathology at Neuberg Anand Reference Laboratory, Bangalore. Sir, your session on leukemias was extremely enriching. From your vast clinical experience in hematology, flow cytometry, and digital pathology, you gave us valuable take home points that residents can immediately apply in your learning, in our learning and practice. So, we also sincerely thank Dr. Aditya, sir, who always have been a constant support for our activities, and the entire KCIAPM team for giving us this platform to learn, share, and grow together. And a big thank you as well to our moderator, Dr. Teja, and all the residents who joined in today. So,
Thank you
you
so
want
much.
to like to say anything, sir, for our residents?
Yeah, so don't worry about how much you are learning. It doesn't matter
Sir, your
because
video is not on. I mean, you're not visible.
yeah, now
No, sir.
no, I don't know.
No,
Is it visible now?
No, sir.
no, sir.
Uh, okay, but I'm audible, right?
It's okay, sir.
Yes.
You
Yeah, so
sorry,
for the residents, it doesn't matter.
audible.
Like whatever you are learning, even no matter how less it is, just even if you see one case per day, it's absolutely fine. Because the actual learning happens once you start practicing, rather. But if you're not picking slides, it's absolutely fine still. Just always go back and see what went wrong or how you can do better. There is nothing more than that. If it's only about correcting mistakes, and just stick to your basics, learn your basics well, and that's it. If anything, they can contact me anytime. I think since they know about pathogag also, they can ping me on Instagram.
Yes, sir. Thank you, sir.
Teja, you have anything to say?
And no, Mohammed, like I would like to apologize for the inconvenience. But it was a great session. We met sir already in the CMV, and that too about the bone marrow, and today about leukemias. We really enjoyed the class, mom. The always connects with the movies so that we remember better.
Of
Yeah.
course. So, thank you, sir. With this, on behalf of the Residence Committee, I express our heartfelt gratitude to Dr. Pradeep, sir, for his time and inspiring talk, to Dr. Aditya, sir, and to KCIAPM for today's session. We look forward to meeting you all again in the upcoming programs. Thank you, everyone.
Thank you. Thank you, sir.
Thank you.
Thank